I am Dr. Aditya Kelkar in conversation with Dr. Nagpal sir. Dr. Nagpal is one of the pioneers of vitreoretina surgery in India. Dr. Nagpal sir doesn't require any formal introduction as such, but he has seen retina surgery develop from infancy to adulthood. We are indeed grateful to Dr. Nagpal sir for spending time with us and sharing his thoughts. So you started your retina practice nearly 40 years ago. It was a time when getting technology was difficult, getting training was very difficult. So what actually motivated you to take up retina as a specialty?
Basically, one thing is that we have always tried to accept the challenges. And in those days, there was a little turning and thinking around the retinal detachment surgeries. People had started getting conscious about that. And there was an opportunity provided to me by the government of Gujarat to shift to Ahmedabad and pursue the specialty of retina. The opposition came right from my head of the department, Dr. R.N. Mathur. He said there is no scope, why you want to go? Hardly any retina settles. But I said, well, let's take up the challenge as it is and do our best in this. So he forwarded the application for transfer. And when he came to Ahmedabad and started working around retina in 1969, we were getting at that time one case of detachment every month in that M&J Institute Civil Hospital, and that too half of the time was in a state that it was inoperable. Anyway, we started doing whatever work came in, and in the meantime, Government of Gujarat sponsored, with the help of the German academic exchange people, and I stayed for a year and a half in Germany working with the inventor of photocoagulation, Professor Maya Schwickerath, who had made the different photocoagulators and was an authority and somebody whom you would like always to talk about that. We worked with him.
You also worked with Professor Ghulam Payman.
No, I have not worked with Ghulam Payman, but I have visited him, he has visited us, he has operated at our place and a number of meetings. But the main reason I appreciate that man is that he was always a great friend of Indian ophthalmology. He was constantly coming to attend the All India meetings and other meetings whichever were held, and was providing all the knowledge and infrastructure help wherever possible. When I say infrastructure help, I mean the used cutters at times he would leave behind. He initially came to Aravind, Madurai, and in 1976, he is an Iranian ophthalmologist, and he was working at the same place 2 years before where I was working in Germany. And so it was an association through the same place of working, though we were not at the same time. So when we met, we became friendly just out of those connections.
So when you returned to Ahmedabad after getting trained in vitreoretina in Germany, what was it like, your initial experience? How was your response from your colleagues?
It certainly improved over our indirect ophthalmoscopic use. we could find the holes which we were earlier not detecting, and gradually working in the civil hospital, we started getting good results and started writing back to the referring doctors, speaking to them in the meetings about the successes and the possibilities, and the referrals came in, and within 6 years, that is, I came back in 71, 76, 77, we were doing 12 detachments a week.
Wonderful.
And we presented out of the 1100 cases of retinal detachment, we presented in 76 at the Afro-Asian meeting the first 500 cases and the analysis of it and results of it.
That's great.
All that changed the status of the management of retinal detachment, and we found people referring and some of the youngsters interested to learn that retinal work. And in 76 we had one person who wanted to do fellowship with us.
Okay.
The fellowship system did not exist in the government institution.
Okay.
We had to take special permission, and so he came in, he stayed for 6 months, and gradually it became a popular mode to learn. What really changed the whole thing was that through the co-observation prisms and mirrors, we kept showing to the younger generation that there is a hole, there is a lattice, which otherwise was for them only in the textbooks.
Right.
As
Exactly. Yes.
no actual fundus picture. And that created a interest in the youngsters.
Right.
But there is something new.
Yeah. So I often remember you used to tell us there was some unique way of treating a retinal detachment with a giant retinal tear in the earlier days, and you also had a specially designed table for it. Can you just tell us something more about it?
Giant tear has always been a problem and still also continues to be a problem, but of now much less degree depending upon the size of the tear. At that time, with the limited experiences and the limited instrumentation available, we were still doing buckling for the giant tear,
I see.
bringing the buckle to a level that wherever the reflected back flap will come over and drain the fluid at 2 or 3 places, even have a tendency to incarcerate some portions of the retina while we drain,
Purposely.
so that it purposely sticks, there. And after it has come near about in contact with the buccal area, do the photocoagulation over those areas, giving absolute rest in the positioning, and in 3 weeks to 1 month's time of all the struggle, we could get 20-30% cases settled. In due course, we found that one can do by movement of the face what was being achieved with a centrifuge, human centrifuge, in which the patient is rotated after putting belts around him on a table, so that there is a movement of inertia bringing the retina back. But that was possible only when the PVR had not set in. Once the fibrous tissue sticks, when the fold become stiff, then there is no treatment available.
So you've trained so many ophthalmologists in India and also abroad. What's your take on residency training in India?
Dr. Kelkar, initially we had the problem that people were not understanding our language of indirect ophthalmoscopy. They had never used in their residency program. The teachers had not known, and what teachers would do, how can the students learn? And so we wanted people who should understand what we are telling them.
Yes.
Otherwise it was a hearsay. I told them there is a hole, and they said, yes, there must be a hole. They've never seen. So we started immediately a 6 months fellowship. It was in collaboration with Badrinath, and we were together at the same time starting work for this purpose. And so we started a 6 months fellowship for training into indirect, as well as the last 2 months of it used to allow them to assist, and some of them, nearly 15-20% of our fellows, would stick on from indirect to surgery, and some of them became. Whereas 80% of them were good indirect ophthalmoscopists, fundoscopists. They could diagnose better than the other, they could guide the patient.
So you, in the last 40 years, do you see there is a paradigm shift between a doctor-patient relationship, and is there a gap which is constantly increasing?
There is a big shift, doctor and the patient relationship, and it's not for the good, basically.
Yes.
His expectations have become very high, and we have created them. Especially the different techniques used as a edge to promote himself and herself.
Yes.
People have tried to make a commodity out of all that. Somebody saying that he can do the surgery without sutures, somebody saying that I can do with one stitch only, somebody saying that I do through a 1 millimeter, somebody saying topical anesthesia, somebody saying, this kind of competition, taking an edge, to the extent that there was a patient who came asking me once that, do you have phaco? And I said, yes. How many phacos do you have?
Okay.
I said, I have one. He said, so and so has got two.
Okay.
So if one machine fails, the other can take over. This kind of edge creating mechanisms were used, and so it has brought the patient to a level of suspicion, plus he demands much more because he wants to compare with it, and the eye surgeon has helped him in it, in boosting this. And today there are times when the expectations, having been raised to a large extent, create the medico-legal complications later on, because the expectations can never be met to the full extent.
Absolutely.
And not all the time will be on it.
So in this current era of modern technology, which according to you are the older diagnostic skills and treatment options that one must never forget, and they are a must even in today's world?